All right, so originally my presentation really was to walk you through the mumps outbreak that we worked with Whitworth University in containing earlier this fall. But I realized for this audience, the topics of measles and mumps and influenza, oh my, is much more relevant. We spend a lot of time, and it's our task as healthcare system preparedness partners to prepare for things like Ebola and Lassa fever and SARS and MERS and some of the big bad scary ones that are our worst nightmare scenarios. There's one national and international attention, and they're also oftentimes the ones that might get stressed from the federal government for us to work towards preparing for. But I would suggest that there are a lot more common.
This is Dan. How may I help you?
That is, for me, it's easier to prepare towards something that feels like we can realistically manage really well. And we still have measles in our country and in our community. We still have, and we have a lot of influenza every single year. To our healthcare institutions in terms of exposures, potential exposures, not knowing staff, immunization staff, and just having staff out ill. So that's, I broadened the topic without the knowledge of my peers, and so we're going to walk through that. Oh, there we are. Oh. What can I do? So the goal together right now is we learned some things as public health. And so my goal today is that there'll be a better understanding of the magnitude of the measles outbreak on our local healthcare system. Can I get rid of that? Appreciate the challenges associated with a mumps outbreak on a college or a university campus. And then to hear about a couple of best practices that could support preparedness efforts right in your facility. And I realize that we are all kind of on a continuum of different preparedness efforts depending on what your facility or agency requires around staff immunity or proof of immunity. But I think it is a continuum, so we'll go through some of that. So measles in Spokane in April of 2015. It was our first case in almost 20 years. So a lot of our medical provider community, especially our younger set that often work in our urgent cares and emergency departments, had never seen a case of measles besides their academic training. We
associated with the Disneyland outbreak in 2014. There have been cases
in Washington associated with that in January and February. And as a state, we were just coming up on clearing Washington state measles free when our suspect case appears. So the clock starts over and we begin our investigation to see if in fact we truly have measles. So measles, from an outbreak, it's airborne and it's highly infectious and it remains contagious in the air in an empty room for 2 hours after the person with measles has left. So just think about those challenges in your own facility and who might walk through a space after we've had a suspect case come through the doors. So it became our mission quickly that as soon as the case was confirmed, we needed to let a lot of people know where they may have been exposed to measles in the community, including 4 different healthcare settings prior to the diagnosis. And again, who would have thought measles especially with this individual who had not traveled at all outside of our community. So we had 75 health workers exposed as a result of eventually getting this individual diagnosed. There were an additional 350 community members that we could distinctly identify as having been potentially exposed to this case based on the movements of that individual prior to isolating them to their home until their infectious period was passed. There's no way as public health that we can find and interview 350 people. So we did rely on the media and all of our partners to share that message about the time frames of where they may have been exposed. And this is that outline. On this side are the locations before the case was actually diagnosed. And then we ended up adding those on the other side as a result of a second case, epidemiologically linked and very closely tied to our first case. So in all of those locations, people had to sort of self-identify if they'd been in that space, and then share their immunity status, or check in with their provider about their vaccination status, or get a titer to be able to know that they were not infected or that they were immune to measles. Of this larger population of 350 public, we were able to document 36% of those as being fully vaccinated. 17% were born before 1957, so there's assumed immunity prior to that birth year. 20% had titers. We were able to provide titers for them to determine immunity status. And so that left 20% of unknowns. So some of our interventions in terms of mitigating those, there were 7 people received immune globulin. 6 of those were infants too young to be vaccinated yet, and 1 was an immunocompromised adult. We were able to partner with PAML to do titers in the basement of the health district, and dozens of people were able to understand their immune status as a result of that. And we also did a huge vaccination campaign in partnership with many around the community to vaccinate any who didn't know their status or knew that they were unvaccinated. The last little blurb is, so as a public health entity, it was a costly endeavor. And we are, because it's my job as public health, to promote vaccinations, we're always comparing it to the cost of having a highly vaccinated community. And so clearly the differential is significant. Related to the measles case, any questions? Because I'm going to move on to mumps. Okay, so just this fall, well, first let's talk about mumps. It's a viral illness. Well, again, a disease that's not really often seen in the healthcare community, so certainly more often than measles. Different symptoms appear. It has a very long incubation period. You're contagious for 3 days before the onset of parotitis and for 5 days after. And it's a respiratory droplet transmission. The MMR vaccine is what we would consider a really effective vaccine at 88% with 2 doses, or 78% with 1 dose. The 12% window became problematic in this particular circumstance. so we had a small group of students in August do a mission trip to India for a few weeks. One of those students came back with mumps. 2 additional cases very closely linked to that individual were confirmed, sharing both. One was on the trip and the other was in a residential environment with the first case. And then we had 2 more probable cases that we couldn't clearly epilink to the first case, but likely linked. So we call those probable cases. And all the cases were students. So Whitworth, like many of our universities, tends to be a really highly vaccinated population. A lot of the schools have requirements before registration that they have documented immunizations against a variety, including measles, mumps, and rubella. And so Whitworth was very similar to the rest of what we would expect in the university population. Only 9 undergraduate students were identified as not having been vaccinated, and it was for medical reasons. But there are mumps outbreaks all across the country, more frequently actually than we realized until this fall. It's congregate living or close residential quarters that are a premium way to spread mumps. A lot of saliva sharing in various means on a college campus, whatever that might look like. So it's tough to control once it's taken hold. We just collected just some of the numbers this year of these universities that had mumps outbreaks on their campus. So it was reassuring to Whitworth in that it's not uncommon to happen on a university campus. But that being said, trying to contain it as quickly as possible so that this isn't an ongoing situation is really important. And then this table here just kind of gives the last several years of how many cases there are across the country collectively. Unrelated to a university setting, northwestern Nebraska as a state currently has 856 cases, and it's growing. And so, certainly it's their goal to put as many mitigation measures in place as possible. And I think that will be a really interesting study just to get a sense of, was it a pocket of the community that's particularly under-vaccinated, where it's taken hold so strongly? We won't know yet, probably till the spring. But vaccination, as I mentioned, is really effective. The incidence rates from 1965 through 2005, it essentially has dropped off to almost nothing, even though we're still counting a few thousand cases per year across the country. So some of the actions that have been taken by Whitworth in conjunction with public health and several partners is we were able to isolate the confirmed and probable cases to their dorm rooms, provide them meals, virtual classroom services, and limit their activity on campus until their infectious time was passed. There were over 100 people who had likely direct exposure to the cases, and as public health, it's our job to monitor all of them. So we were able actually to use texting technology this year to monitor those individuals. We were monitoring them every other day for their infectious period, which was 25 days. Some required a phone call, but not many. And then our monitoring period actually just ended last week with no additional cases. They're still considered an outbreak status until we have a full second incubation period passed, which will be December 5th, and I think we'll all be celebrating at that point. But Whitworth verified the immune status of all their students. They knew they had the policy in place, but they wanted to make sure that they actually had followed their policy for their students. And for the undergraduate population, they had. The graduate population and staff and faculty were a different issue. they did not have the policy in place in terms of verification of immune status for their staff and faculty. So we were able to provide vaccination clinics, thanks to Group Health actually buying MMR and Walgreens dispensing it. And in partnership with Pathology Associates, several titer clinics were also provided so people could learn their immune status. They had one additional record-keeping snafu in that they were transitioning from paper records to electronic medical records at the beginning of this school year. So there were records in a multitude of locations, and so that was a complicating issue. But I think they feel like they've come out with some incredible lessons learned about really paying attention to the importance of knowing their staff status, even though their goal had been to really focus on the health of their students. But without teaching faculty or setting up enough virtual technology so that a faculty person could teach out of their home in isolation to their class, which those pieces weren't in place either. It seemed like a really relevant and applicable to this group in our healthcare environment is how do we keep our staff and our operations going in the face of maybe not knowing the status of every staff person that works in our facility for common illnesses. Related to sort of the question around, why does any of it matter, and isn't there enough herd immunity to protect our greater communities? And I just thought I'd show this slide, and there's one more, just as an example of, our thresholds for herd immunity are pretty high. And as I mentioned with mumps, Whitworth was in that threshold at 88% of their students, more than 88% of their students, I think it's closer to about 98% of their undergraduate students had 2 doses of MMR on board. Yet there was enough presence of that 12% that the vaccine doesn't cover. It's not a 100% guaranteed vaccine, that we could still have 5 cases in our community. So I think we can take solace in herd immunity, but I think when we're in very specific environments, and in particular healthcare, we can't count on herd immunity to make sure our patients and our own staff are protected. And I'm actually going to kind of skip through this one. It's a visual picture of the percentages. And then we move on to the more common illness that we get to experience every year, and that's influenza. I spent the morning actually looking for statewide data, Eastern Washington data on influenza hospitalizations. But there's only a couple of counties in our state that track hospitalizations. It's not actually a requirement. Only deaths associated with influenza are required. So our season has started. We've had 5 hospitalizations so far in Spokane County, and in the age range where we would expect them, above the age of 40, and certainly the numbers get higher over the age of 50. And then this is a graph of the last, looks like 6 years of what the influenza curve looks like across the season. In 2014-15, we had a really early influenza season, and that's the yellow line that spiked up between 200 and 250. We expected a second spike that season, since our season is typically a little bit later than December, and we didn't have it. So that was a nice surprise, because you can see typically peak sometime between January and March. Again, I apologize that it's Spokane County only information. So trying to relate all of this again back to our goal as a healthcare coalition and helping our healthcare system be more resilient and to be able to respond to whatever is happening in the community. These types of common illnesses, and certainly the more catastrophic that that may keep us up at night in terms of thinking about Ebola or MERS, all of them pose the same types of threat. Just the severity of the threat may vary. In that we may lose time to initiate our response because we're trying to figure out the immune status of the staff that we need to work. Or it reduces our staffing power because it's impacted the reserve of staff who we may need to draw on to help us keep our doors open and provide quality health care even as we're needing to surge. Unvaccinated staff are at a greater risk of exposure from sick patients, and in return, staff are at a greater risk of exposing our vulnerable population, oftentimes before they either know that they're sick or they're not really sick enough to go home yet. So a couple of the interventions that I wanted to share with you that may already exist in your facilities, and I'm going to ask that question, our Board of Health, we wanted to focus really on the long-term care environment as public health this year. We have an infection prevention position as part of a pilot project from the Centers for Disease Control, who's working with long-term care around infection prevention practices. And so we went to our board and asked if they would consider a resolution, which has no teeth in the sense of enforcing anything, but we wanted them to share a resolution with the community that they, as a Board of Health, support influenza vaccination policy or masking practices during seasonal flu. And we were specifically looking at the long-term care environment, knowing that 90% of that population is extremely vulnerable. They actually asked us if we would broaden, and they'd like to make a broader resolution to all healthcare workers. So that's what this resolution is. Encouraging all healthcare facilities to adopt policies that that mandate their staff to be vaccinated for influenza every year, or to be consistently encouraged to mask during flu season if they either choose not to be vaccinated or can't be for other reasons. It also encourages healthcare facilities to develop a comprehensive strategy for their staff to be supported with influenza vaccine. So targeted education about risks of disease to personnel and to patients, vaccine safety and efficacy information, making vaccine really accessible either on their campuses or in the community, and time to be able to be vaccinated. Encouraging that those facilities provide influenza vaccine at no cost, or even friendly competition between a floor or between units around a level of immunization status for influenza. And then again, to consistently enforce masking for those staff who are unable to be vaccinated. Long-term care environment is typically where we get all of our hospitalized cases, whether they're being cared for in an in-home service or in a facility. It's a vulnerable population, and I think we all know that. There's a lot of mingling in long-term care environments with residents and staff and family members who are visiting, so the opportunities for exposure happen frequently. So there is this last bullet here was really what helped our board understand that we have a local example, Virginia Mason Hospital in Seattle, who I want to say they're in their third or fourth year of mandatory influenza vaccinating, and they're up at 98% of their staff annually being vaccinated for influenza. Where prior to that, even with good effort and encouragement, so without a comprehensive strategy and actually making it mandatory, they were around 30 to 50%, which is really representative of the rest of the community. we get happy as public health when we're at 50% vaccination status for influenza on any given year. And then the second strategy is really around internal policy. And this is where I think my guess is a lot of policy already exists in the healthcare environment. We as public health are just now putting this in place in our own agency. We wanted to establish requirements and recommendations for designated personnel, depending on what they do for the health district. We also wanted to have it understood that we have really clear expectations as public health that staff will be properly immunized, and that it's a self-protection and client protection measure. So it's a win on both sides from our estimation. We have two categories of vaccinations for staff. Those who have direct patient care and contact, so it would include the risk of respiratory exposures as well as a bloodborne or body fluid exposure. And then our category B staff. Those are the staff that work closely with people face to face and so have respiratory risk, but don't otherwise have needle stick injury risk and that sort of thing. And these are the immunizations that we designated for each of the two categories. So category A being the more direct for MMR, Tdap, varicella, hepatitis C, and influenza. And then category B being actually all of those except hepatitis C. We're doing a phased-in approach, so folks that have been at the health district are grandfathered in terms of cost to themselves if they're in a program where they need to be vaccinated based on what they have to do, and they're not able to have proof of immunity just because maybe records don't exist or they have been able to get their records. The health district will assist in making sure their records are up to date and they can prove either through titer or vaccination. But all new hires will be required to meet the criteria for either category A based on their job classification or category B. So at this point, I really wanted to ask you, how many of you have, that you know of, policies in place that are reviewed regularly for immune status of your staff? Good. And it doesn't, the hospital hands don't surprise me. But I think sometimes outside of the hospital environment, I mean, honestly, as public health, that we're just getting this in place ourselves, maybe isn't something I should be admitting to you, but at least we're finally there and moving forward with it. And anyway, so that was what I wanted to share with you and kind of tie it back to making sure that our workforce for response is ready and able to go no matter what it is that we're dealing with, and that we're most likely dealing with something that's far more common to our realms of knowledge than the exotic and extremely scary. So those are very real threats. Any questions?